That's a definition of resistant hypertension in the European guidelines, which are the most contemporary blood pressure management guidelines that we have. So BP, where you've not achieved less than 140, 90, and you've proven that the control is inadequate with either home or ambulatory monitoring, and you've confirmed adherence. That's really important because I think we've all been involved with the management of patients where we're bringing them back time and time again, and they tell you they're taking the medications. In fact, there's a lady I sent, it's when we were looking at renal denervation, the trial that we were looking at doing with Rob. We had her on the waiting list to come forward for renal denervation. She was on 5 antihypertensive medications. Every time she came in, her blood pressure was 180 over 100. She happened to get admitted to hospital with something else, and she was taking her tablets in hospital because they were dispensed and people. She was taking her tablets, and her blood pressure was 110 systolic. So she wasn't taking her pills. But the prevalence of resistant hypertension is probably around 10%. We don't have a really good idea of what this is in New Zealand, but that's the international estimates of the prevalence of resistant hypertension. The importance of this is that this group are much more likely to develop the complications that we see associated with hypertension, be it hypertension-mediated organ damage, chronic kidney disease, and premature cardiovascular events. So again, got to exclude. This is their typical treatment algorithm, usually 3 medications, an ACE and ARB with a diuretic. You've excluded pseudo-resistant hypertension, and secondary causes should also have been excluded where it's appropriate to investigate for secondary causes. I'll just skip through that. This is from the European guidelines, and again, these slides are available to you. I think this is a nice algorithm, and Bruce, I don't know if you've looked at this in much detail, but it's the stepwise approach, and the Europeans now recommend 2 pills for everybody you and I see when we are going to initiate pharmacotherapy for management of hypertension. In the UK, they've got various combinations that we do not have available to us. So stepwise incrementation, you add a 3rd medication, resistant hypertension, and their go-to drug is spironolactone. And again, what's nice about the European guidelines, they give you modified algorithms for concomitant disease. So if someone's got ischemic heart disease, they would say, it's obvious we should have that patient on a beta blocker. So that's one of your first-line treatment options in someone that's got concomitant ischemic heart disease. Acknowledging that beta blockers are not particularly effective antihypertensive agents. Bruce, comments on that? I mean, that's...
No, I think, I guess the problem is most of us are pretty comfortable using them. Except atenolol. Atenolol should be off so bendrofluozide should be off the market, and so should atenolol. And I think the thing, my understanding of atenolol is it lowers the peripheral blood pressure, but not the central blood pressure, I think is the thinking. And when you look at the reviews, it doesn't seem to be as good as the other. And I've tended to go on to bisoprolol now because it's got 4 steps to get to the maximum. With metoprolol, it's 6 steps, and the patients think they've been poisoned if you keep going, increasing the dose. So 4 steps if you want to get to maximum.
And certainly it would be my preferred beta blocker today. I would rarely initiate metoprolol. I would initiate bisoprolol, be it for heart failure, angina, or if I'm using it in a hypertensive patient.
The other thing is there's a supply issue with the metoprolol we had about a year ago. So, because we tend to use a lot more of beta-lock here than other countries, they tend to use the succinate, I think, don't they?
Yep.
We use the tartrate, or vice versa.
So again, you or I have seen someone we believe may have resistant hypertension. These are the things that we need to consider when we're during the consultation with the patient. So lifestyle factors, excessive alcohol consumption, sodium intake, as Bruce alluded to, other medications that may adversely affect blood pressure. Don't forget this entity here. I think this is a really important cause of hypertension. that we don't recognize or investigate enough. So you've got an obese person in front of you whose blood pressure's up. Please think about obstructive sleep apnea syndrome. Ask the appropriate questions, Epworth sleep score, whatever it is there. But you know, you don't need to do that. It's not, you know, if someone's got disturbed sleep, they're a snorer, they've got apneas, they've got daytime somnolence, they're overweight, that person, in my opinion, particularly if they're hypertensive or got increased cardiovascular risk, they should be referred for a sleep study. Not that easy to get, I think, around the country. I don't know what access is like in
most in counties, most of our patients get a pulse ox overnight. What's interesting, although that can help the blood pressure, it doesn't change cardiovascular outcomes. The big trial in Australia, but they sleep better and they're happier. The key thing with sleep apnea is people are really tired. So you've got somebody who's falling. I had a guy, he worked for a bank and he was falling asleep. His office mates were having to wake him up. I mean, or falling asleep in the somebody asleep in the waiting room. Do their Epworth, and you'll find that we have to do an Epworth to get an assessment.
So you would refer to counties, and they would do it overnight saturate.
Yep.
And how's that done?
They give them a finger thing they take home.
Yeah.
Very few people seem to go to the lab anymore.
Okay.
I don't know who gets into the lab. You know, it's just too expensive, I think.
Yeah. Certainly, it's not something that we do sleep studies, and we have a reasonable access to sleep studies in Terrafferty and around about the rest of the country.
There are private companies. I don't know whether you've got any in Auckland. There are private companies there's a couple of private companies that'll do overnight for about $150. But then the only advantage going to the public system with us in counties is you get a free CPAP machine, which if you go privately, then you're stuck with paying for it yourself. So.
An overnight oximetry, is that something larger primary care practices could do?
Yeah. That wouldn't be hard to do.
Yeah.
It's not expensive.
That's
It's just, you know, an oximeter.
Okay.
On your finger overnight.
So again, think about these. You're seeing someone who you believe may have resistant hypertension.
24-hour readout.
Is it worth looking for causes of possible secondary hypertension? And again, advanced hypertension-mediated organ damage. The one that we tend to look at specifically, if you refer someone to me, I will look for LVH on an echo, an ECG. But there's other markers of that, isn't there, as well, retinopathy, and how the kidneys are performing as well. I think this is a problem in older people, and may reflect one of those patients that you mentioned earlier, Bruce. You know, large artery stiffening, and we keep chasing the holy grail of lower and lower and lower. And someone who's elderly and their vessels are very stiff, we're not going to get it, and we need to, you know, recognize what we're doing. How many people routinely check lying and standing blood pressures? Okay. So if you've got an elderly person in the rooms that you're looking at commencing an antihypertensive or up-titrating antihypertensive agents, would you look at lying and standing blood pressures? Yep. And you'd make your treatment decisions based on what? The lying blood pressure or the standing blood pressure? I'm going to ask Bruce in a second. Bruce, I'll let you go first.
The standing one, well, that's what's going to make them.
Yeah, because I've seen people, and I think we've all seen people, you know, their lying blood pressure looks elevated. You're thinking, should I start something? Should I escalate therapy? You get them to stand up, and there may be a 20-30 millimeter drop in systolic blood pressure, and that's the one that I would tend to use. And I think, particularly in elderly people, I think we should be routinely measuring lying and standing and making our treatment decisions, particularly if we're thinking of escalation of treatment, on what the standing blood pressure is. But again, just in a different format, this is just to emphasize populations in which resistant hypertension is more likely to occur: older, people with diabetes, people with chronic kidney disease, established coronary artery disease, and male sex. Pseudo-resistant blood pressure, that's the definition of it. Poor adherence, white coats, these are what we should be thinking. So these are what we should exclude before saying someone has resistant hypertension, not pseudo-resistant hypertension. So look at adherence, the white coat effect. You mentioned this earlier, Bruce. I don't think we consistently measure blood pressure well. We don't measure it the same every time we measure it, and I think we need to, remind ourselves.
Get our students to palpate the radial artery, because we had a student one day record something as 120 on 80, and actually it was 180 on 80. So he missed, by not palpating, he missed the true systolic. So.
Yeah.
But most of the registrars, apparently, when they sit there part 2 or part 1 or whatever, they don't do it either. It seems to have gone out of fashion a little bit.
Really?
Yeah.
So they're not out?
Yeah.
Brachial artery calcification, and I think this is real, isn't it? Clinical inertia. We let people off when they come in because one blood pressure's up. They come in again, it's up. We thought it's a white coat effect. So I think we need to guard against that. And also irrational combinations of blood pressure lowering medications. So I'm not going to go through that. You mentioned that earlier, Bruce. And that's just some indications. So again, diagnostic approach to someone you're seeing who may have resistant hypertension. Take a good history, other drugs, sleep history, adherence, the pattern of medications that they're actually on, the dosing of the antihypertensive medications. Consider end organ effect from hypertension, confirmation with ambulatory or home blood pressure monitoring. And again, look at these. These are important blood tests: renal function, electrolyte status, think about diabetes, and secondary hypertension. These are the recommendations of the European guidelines. 1B saying there is a little bit of evidence, not a lot of evidence about what we should do. And again, their go-to fourth-line therapeutic agent is spironolactone, but also consider eplerenone, amiloride, or high-dose thiazide-like diuretics. They suggest we use these agents with caution in patients who have got significant renal dysfunction, defined with it by an eGFR less than 45 or a potassium above 4.5. This is the trial that I just wanted to share with you, that this is based upon the Pathway 2, and this was published in 2015, where they looked at different combinations, including placebo, spironolactone, doxazosin, bisoprolol. In blood pressure lowering, they looked at the delta change in blood pressure, systolic blood pressure, and the greatest change that they got was in spironolactone, almost a 9 millimeter reduction compared to placebo, and about a 5 millimeter reduction compared to the other drugs. And these other drugs, so they do have some effect as well in that resistant population compared to placebo. So there is some science behind why spironolactone should be the first go-to agent. So secondary hypertension, just some quick slides on this. I think secondary hypertension, a lot of people with secondary hypertension, it's rare, but it may be curative if we pick it up early. So someone with fibromuscular dysplasia causing renal artery stenosis, it's potentially curative if we diagnose that. So you have to have a high index of suspicion, and that index of suspicion should be driven by the patients in front of you, so the age of the patients in front of you, and the other things going on and the other symptoms that the patients may or may not report when you're seeing them. It's nonsensical to screen everybody that you or I see with resistant hypertension for secondary causes, acknowledging that a lot of the people we see with resistant hypertension will be elderly populations. So consider it in younger patients, acute or worsening hypertension in someone who's previously been stable. I think that's an important thing for us to consider. The presence of lots of hypertensive mediated organ damage. If there's electrolyte or biochemical disturbance, you should think why the potassium is low, this doesn't make sense. Obstructive sleep apnea and symptoms suggestive of pheochromocytoma. We've diagnosed a pheochromocytoma this year, so we do see it occasionally. It was someone that came in with tachyarrhythmias actually, but also blood pressure was quite labile and going all over the place, someone that we were following routine post-valve follow-up, and she's been diagnosed with a pheo and is awaiting surgical treatment of that.
They found the tumour?
Yes,
It
yes.
was in the adrenal gland? or
Adrenal,
elsewhere?
just above the adrenal. Just
Yeah,
above
I had
the
a
adrenal.
guy with one in the back of his, also this year, first time,
Yeah.
only one I've ever found. So
Yeah.
I didn't find it actually. They found the tumour and then they realised it was a FIO.
So again, just some common ones for us to consider. Obstructive sleep apnea, we've mentioned. Reported prevalence up to 10%, so it's an important cause of someone you or I seeing of secondary hypertension. Renal parenchymal disease, and I think that's an important one. I certainly always ask about this in young people. Have you had any kidney problems when you were younger? Recurrent UTIs when you were younger? I invariably will do an MRI in most people I see who are young with hypertension. And we'll also look at urinalysis.
What do you call young? Gerry?
I think hypertension below the age of 40, I think, is something that I think is worthy of us considering.
More so in women than men, because I heard with women under 40 it's more common than in men under 40.
Yeah, I wouldn't have a differentiation based on that. But again, older people get atherosclerotic disease. They may have atherosclerotic renovascular disease. As Bruce mentioned earlier, this tends not to do well by putting stents in the renal arteries. We don't influence outcomes of blood pressure much at all by doing that. Younger people, this is curable actually. This is curable if we pick it up and manage it early. I think this is one that we all consider. The complexity of this is when you or I are seeing someone who may have secondary hypertension, they often are already on lots of medications, and it makes it quite difficult to interpret these blood tests. And if you would refer someone with suspected primary aldosteronism to an endocrinologist, what they would ask for first is stop all the medications, please, and let's start again, because it makes these bloods difficult to interpret. FAO, the 5 Ps. I'd forgotten about the 5 Ps. I'm not even certain I knew the 5 Ps. But paroxysmal hypertension, so blood pressure that's up one week, down the next week, pounding headaches, perspiration, palpitations, and pallor. So if you've got someone, particularly a younger patient, think about that. But also, the lady that we picked it up in recently was in her 60s. And you're familiar with these conditions as well. And coarctation we mentioned. Over my career as a cardiologist, I've probably managed 4 or 5 people with coarctation, with hypertension, who've responded well to management of the coarctation itself. A lot of them actually will come back to needing antihypertensive medications. And again, certain things are more common in age groups. So you think about renal parenchymal disease in younger patients. As we get older, these things become more common. Atherosclerotic renovascular disease in our aging populations. And that's a list of medications that's available for you. So just finally to finish with a summary of resistant hypertension. The characteristics: older, overweight. Think about dietary sodium intake, as Bruce has mentioned. Concomitant diseases, hypertensive mediated, organ damage. LVH is the one that we tend to look for. And certainly if I'm seeing someone that's had blood pressure around for a while, I will tend to do an echo. I guess I've got access to an echo. Diabetes, atherosclerotic vascular disease. The commoner causes of secondary resistant hypertension: aldosteronism, sleep apnea. Uncommon causes, think about these drugs here, as Bruce mentioned earlier. Non-steroidal is probably the one that we see most in day-to-day practice. I think it's a difficult one to address, with someone who is functioning because of the non-steroidals, and you really would like to stop the non-steroidals for fear of renal dysfunction, sodium retention, be it for heart failure or blood pressure. I think I look at the person and what's important to the person. So I don't make decisions based on cardiovascular risk or what I'm trying to achieve per se. It's what's important to the person.